Hello. The presentation today is entitled Opt-Out Florida, presented by Tatiana Amaya, Danielle Chung, Leila Hernandez, Samantha Hermida, and Tululepe Olagbua. The presentation aims to provide an advocacy action plan to support removal of the physician supervision requirement for certified registered nurse anesthetists in Florida. The presentation will be split into 5 different sections. The 60-day action plan for Florida opt-out, timeline of activities, followed by the fact sheet, letter of support, and finally, frequently asked questions. The 60-day action plan was composed by a subcommittee of SRNAs and CRNAs involved in the 2021 Political Action Coalition, or PAC, for Florida as an opt-out state. Our organization, FANA, aims to further patient safety and the CRNA practice via advocacy, education, and member engagement in Florida. Moreover, our PAC seeks to opt the state of Florida out of the Centers for Medicare and Medicaid Services federal supervision mandate of certified registered nurse anesthetist requirement to be supervised by a physician. In order to accomplish this goal, support must be attained by outlining the importance and benefits of Florida as an opt-out state. Evidence-based practices and research endorsing CRNA independence will be used to advocate and recruit volunteers. FANA volunteers, combined with lobbying efforts, will help undertake the task of changing legislation. Within 60 days, a timeline has been created to outline how we plan to carefully manage time and resources to accomplish this goal. Various platforms will be tapped into, including social media, local news, and radio stations to garner support. Additionally, town hall meetings with hospitals, healthcare providers, and stakeholders will be held. Meetings and conferences will be coordinated with major organizations to address the need of Florida as an opt-out state. Key legislative figures will be targeted to help create this change. The timeline of activities for the opt-out Florida proposal will occur over 8 weeks. In week 1, we will identify organization goals and objectives, develop a mission statement, organization structure, and assign roles and responsibilities, reach out to CRNAs and SRNAs to increase awareness and engagement, and contact community leaders and involve nursing and medical organizations to support Florida as an opt-out state. In week 2, we will remain informed of current Florida nursing laws and legislation trends throughout the country. We will enhance public knowledge by providing accurate CRNA information via websites, social media, and other platforms. In week 3, we will organize town hall meetings with hospitals, healthcare providers, and stakeholders to increase knowledge and support, initiate virtual campaigns, and enroll volunteers into coalitions. In week 4, we will delegate volunteers to partake in activities that raise awareness of current laws and benefits of Florida as an opt-out state. We will also inform individuals of who to contact and how to help make a difference. In week 5, we will hold an informational meeting with the public, provide pamphlets and surveys to educate and evaluate the public understanding to support Florida as an opt-out state, hold meetings with FANA members for continuing support, and reevaluate the mission and goal, and review performance. In week 6, we will encourage the public, FANA members, SRNAs, and CRNAs to write letters of support to lawmakers, have a petition signed to present to state lawmakers, and focus on any weaknesses and opportunities to educate the public and hospitals. In week 7, we will meet with all stakeholders and the public to present the benefits, importance, and key points. We will also present a formal letter to the government official of the state of Florida. In week 8, the final week, we will analyze the progress and outcomes and make changes as needed, and also meet with lobbyists and all associated organization members to finalize the outcomes. CRNAs are a clear solution to Florida's healthcare struggles. The following slide will present a fact sheet regarding the proposal of Florida as an opt-out state. The previous federal requirement mandated that CRNAs must be supervised by a physician. On November 13, 2001, the Center for Medicare and Medicaid Services, also known as CMS, published a ruling allowing states to opt out of the federal supervision requirement. For a state to opt out of the supervision requirement, the governor of the state must send an attestation letter to CMS. The letter must state that the governor consulted with the state's Board of Medicine and Board of Nursing, that the opt-out is in the best interest of the state's citizens, and that the opt-out is consistent with state law. The state opt-out will go into effect immediately once the letter is submitted. As of 2020, 19 states have opted out of the federal supervision requirement. CRNAs have provided anesthesia services in the United States for more than 150 years. CRNAs were the first nursing specialty to receive direct reimbursement rights by Medicare in 1986. CRNAs are highly valued in today's healthcare environment. They provide the same safe, high-quality anesthesia as other anesthesia providers, but at lower costs. CRNAs are recognized for providing superior anesthesia care with reduced expense to patients and insurance companies. Research shows that CRNAs are the most cost-effective anesthesia providers. Anesthesiologists are paid about 2.5 times more than CRNAs. However, Medicare pays the same fee for anesthesia service, whether it's provided by an anesthesiologist, a CRNA, or both working together. This means that the higher compensation for anesthesiologists is taken on by the hospital, healthcare facility, or patient. There are over 49,000 CRNAs in the U.S. that provide more than 40 million anesthetics to patients each year. The expanded scope of practice allows CRNAs to provide anesthesia services in areas where those services would not have been otherwise available, such as in rural, inner city, and other medically underserved areas in the country. CRNAs practice in every healthcare setting where anesthesia is delivered, from large hospitals to doctors' offices. CRNAs are the primary anesthesia care providers in rural America to maternity patients, in the Veterans Administration, and in many medically underserved inner-city communities. Allowing CRNAs to function to the fullest extent of their education and training is not only recommended by the Institute of Medicine, but it is also a necessary change to ensure continued access to quality care for all healthcare consumers. Nurse anesthetists are required to have a minimum of 7 to 8 years of experience, education, and training before becoming CRNAs. CRNAs are highly educated, advanced practice registered nurses. Their method of delivering anesthesia to patients is equivalent to physician anesthesiologists. Multiple research studies confirm that anesthesia care is equally safe regardless of whether it is provided by an anesthesiologist, a CRNA, or a CRNA working with an anesthesiologist. Encloses a letter of support for the Florida opt-out written to Governor DeSantis. Dear Governor DeSantis, considering the current state of health nationally and globally, there is no better time to address the access, quality, and cost of healthcare. The unfortunate events surrounding the COVID-19 crisis led to the temporary lifting of physician supervision of certified registered nurse anesthetists. Removal of these restrictions demonstrated the benefits of full utilization of nurse anesthetists. For more than 150 years, CRNAs have provided an essential service to patients requiring surgery, and are the primary providers of anesthesia care in obstetrics, the military, and underserved areas. These valuable, cost-effective practitioners, many who are doctorally prepared and undergo similar classroom and clinical training in anesthesia care as anesthesiologists, should be extended the same practice autonomy. Presently, the Centers for Medicare and Medicaid Services require physician oversight for CRNAs practicing in the state of Florida. This obligation contributes to higher reimbursement rates and the increasing cost of health care. These costs compromise access and the delivery of health care, which has a significant impact on our families, communities, and the overall health of the population. Currently, 19 states have elected to opt out of this requirement, allowing CRNAs to practice independently to the full extent of their scope of practice, and have experienced improved outcomes as a result. Addressing the potential for future staffing shortages, the VA has also proposed changes that will expand the practice authority of CRNAs. Maintaining that scope of practice restrictions and physician supervision requirements for nurse anesthetists have no impact on anesthesia patient safety. In fact, no differences in patient outcomes were documented when anesthesia services were provided by CRNAs, anesthesiologists, or CRNAs supervised by physicians. Along with Florida's Board of Medicine and Nursing, you have an opportunity to improve circumstances while lowering overwhelming healthcare costs. Improvements in access and affordability of anesthesia care are grounded in strategies to promote the independent care of CRNAs. Involvement of community leaders, healthcare professionals, volunteers, and the Florida Association of Nurse Anesthetists in the development of these strategies cements the importance of this issue in the state of Florida. And failure to do so may contribute to healthcare disparities with devastating long-term effects. Your decision to make Florida an opt-out state and granting CRNAs full practice autonomy is critical to improving healthcare delivery, access, and furthers the support of better outcomes. Sincerely, the Fana Rory Subcommittee. On this slide, we will address frequently asked questions. Question 1. What role has CRNAs played in the military? During World War I, CRNAs were the main providers of anesthesia care. Today, CRNAs have full practice authority in every branch of the military. Question 2. What are the barriers interfering with adoption? Surgeon perceptions of increased liability and resistance from anesthesiologists are barriers CRNAs face in gaining independent practice. Question 3. Do CRNAs affect medical liability? Review of case law supports the fact that surgeons are no more liable when working with CRNAs than with an anesthesiologist. CRNAs are responsible for securing their own liability coverage, just as physicians are. The quality of care provided by CRNAs has gotten better over time. Therefore, professional liability premiums are 33% lower today than 25 years ago, or 62% lower when adjusted for inflation. Question 4. Are CRNAs qualified to provide independent care? Yes, CRNAs are qualified due to their certification, education, and licensure. They are the only anesthesia professionals with critical care experience prior to beginning formal anesthesia education. Question 5. What factors affect quality of anesthesia care? According to the AANA, anesthesia outcomes are affected by attention, concentration, vigilance, and organization, not whether the anesthesia professional is an anesthesiologist or a CRNA. Question 6. What were the results of suspending supervision requirements during the pandemic? In March 2020, CMS temporarily suspended the supervision requirements to increase the capacity of the care delivery during the COVID-19 pandemic. CRNAs were among the top 20 providers that served care to the most people from March to June 2020, the height of the COVID-19 public health. The references provided on this slide aided in the development of the Opt-out Florida project. This concludes the presentation. I hope the information provided clearly detailed the background, goals, timeline, and plan for opting Florida out of CRNA supervision. We welcome any comments or questions. Thank you for taking the time to watch.